This email from us two gave us access to Prostopedia, which concentrates on anxiety and depression. This particular issue does. And what was interesting, there was an article by Chuck Strand, which I'm sure is why us two circulated, and I have to send him a little note. And at the end of that little note, our groups were referenced. How about that?
Ah, cool.
Very cool.
Yeah,
So,
very good.
yes, there was but it said joined by telephone. It was virtual, but that's okay. Close enough for government work. So I was very pleased to see that this morning. Well, you'll get the you will get the. Okay. Wait a minute. I wonder if. No. I wonder if I wonder if there's a link to this that I can put in the window.
So I clicked on the one link, Rick, and got the Prostopedia February issue.
Right.
If it's like about 17 pages long.
Yeah. It takes a while to download.
I got it already.
Oh, okay.
I got super internet. You know, I'm an IT guy.
Yeah. Well, Bill, post the URL for that in the chat window.
All right.
And maybe other people can see it. And if you scroll down, it's one of the last articles. There's a couple of good articles. There's a great article by Alicia Morgans. Really good. I already sent it to one of my caregiver people. Really good article by Alicia Morgans. If you keep scrolling down, you'll see. Anyway, we'll talk about that maybe in a minute. Who are we welcoming on the telephone?
Jim Harrington, Rick.
Jim Harrington, number one. Hello, Jim.
Oh, that's nice.
Always number one, Jim.
Yeah, thanks. That's great. Yeah, it makes me feel really good. I asked my wife to call me professor, but she doesn't do it. So.
We call you professor.
Yeah, I know. Thanks, Rick.
And who else is on the telephone?
I am Nelson Pacheco, and I'm this Skype-looking thing, web thing from Virginia. Yeah. My first time calling in. In fact, it's my first time doing this type of conference.
Okay,
so
well,
I hope Nelson, I can figure it out.
You are very, very welcome. We are delighted that you are with us, and hopefully it may be the first time, but it won't be the last time. That's our goal.
I hope so.
Okay.
I'm sorry, what did you say your name was?
Nelson is my first name, Nelson Pacheco, and I'm in Virginia.
So you used the GoToMeeting link, Nelson?
Yes, I did.
Yeah, there should have been a place in there for you to put your name, and it would appear on the web. It would appear on the web, and we could all see it. But I think Rick can add it to.
I did add it, but I added it to caller number 2, and that's not the right person.
No, he's on GoToMeeting. He's the one who says waiting for name under the identifier.
Certainly, I can add.
So,
I can add.
You know, as I say, it's my first time doing this. So, am I visible? Can you see me? I see you guys.
No.
I don't have my web camera turned on.
Okay. Well, never mind.
We also cannot rename him if he's on the web.
Oh, you can't? He has to do it from his side?
Yeah.
For some reason, my webcam doesn't want to show up on the screen.
Well, not to worry.
Rick, you up on camera, Rick? Because I don't see you either.
I'm on camera.
Yeah, mine's grayed out.
Len's on camera, and David Sibley is on camera. Hi, David Sibley. Welcome to the right meeting.
Hey, yeah, thank you.
Now.
Well, I was in yesterday's meeting too.
You were, yes, you were. welcome, welcome. But you knew you were in yesterday's meeting.
I did know I was in yesterday's meeting.
Yes, well, David.
I usually know where I am.
David wasn't sure which meeting he was in, but now he knows.
That's it. You're right there.
I'm gonna disconnect and reconnect, see if my camera will come up.
Okay.
For some reason, it's not working.
So,
Got tape over it?
No, I got it open. I don't see anybody else either. It's the webcam function is grayed out for some reason.
so who else is on the telephone?
I'm on the telephone. This is Sylvester Mann.
Hello, Sylvester.
Hello, everybody.
Number 3. All right,
Got it.
I'm gonna keep writing names. I'm gonna.
Hi, Sylvester.
Hello.
We missed you lately on Inner Conversations.
I wasn't home.
Oh.
Plus, I got my days mixed up. It changed, I think, to Wednesday.
It did.
Well, we've known all along your calendar challenge. You and me both.
In fact, I was getting ready to ask today, how many meetings are there? That was a meeting yesterday?
There was a meeting yesterday.
The meeting
but that was
yesterday.
low risk.
Yeah, it was for low risk and intermediate. Sorry, Jake. So we
right.
have if you go to our website, Sylvester. Oh, I don't know. Are you on the internet or not? I can't remember.
Part-time. I'm not sure what I'm on. I got this computer, but I don't know how to use it.
Because we have a calendar on there. But the meeting yesterday is a meeting for the low and intermediate risk people, which you are very welcome to join. But that's a different meeting. Okay,
To answer your questions, Sylvester, tomorrow at 8 o'clock Eastern time is the Inner Conversations for prostate cancer. We have one every Wednesday now. The first and third Wednesday, it is for Inner Conversations for all cancers. The second and fourth Wednesday, it's for prostate cancer only. The one that we used to have on Thursday is now on Wednesday.
Okay.
Oh.
Thank you. Thanks.
Okay. Now, let me.
We'll be sending you notes if you don't show up tomorrow.
I'll do my best to show up tomorrow.
Okay. Good. We'll be glad to see you.
So
Still have one caller that hasn't identified.
that's okay. It's
Peter.
Oh, it's
Peter calling. I'm calling from a car. I'm calling from my car.
Okay.
Okay.
All right.
Hi, Peter.
Okay, Peter.
Got it.
So let me just run down who I see on the meeting, and if I've missed anybody, you'll let me know. Jake, Len, Nelson Pacheco, Bill Franklin, David Sibley, Jim Harrington, Larry Fish, Paul Frieda, and Peter Kapka. Anybody else? No? Okay. So
And
yes.
Peter, Peter Pacheco, you got him, you said? Yeah. He's the one who's waiting for name. Okay, gotcha.
Yeah. So Nelson, let me explain to you how we work, and if you would like to tell us a little bit about yourself, that's fine. Normally, if we have anybody who has never been on the call before, we are very happy to dedicate some time to you at the beginning of the meeting to hear about your situation, a little bit about your background, your disease, what brings you to this call, and what sort of problems you're facing now that we might be able to give you some guidance on. And if that's okay by you, then we're very happy to start with you. If you'd rather just listen for a while and we can come back to you, we can do that too.
Well, thank you very much. No, I'll go ahead and give you a little background. let me just say that I could only be here until about 7 o'clock because I have another commitment, and the reason is because I was looking for a TOO group locally, and I thought there was one tonight for advanced cancer, prostate cancer, and I was ready to go, but then when I looked a little more and called, I found that actually that group is apparently it's either not meeting or probably disbanding. So I didn't know where I could find a group, and then I found this virtual group, and I was very happy.
Okay.
So I guess I'm 72 years old. I have came down with prostate cancer in 2009, Gleason 3+4, had robotic surgery, upgraded to 4.3, 4+3, with a tertiary 4+4.
Mm-hmm.
The surgery went fine. As far as the cancer goes, I had a very good nadir of 0.01, but gradually it took 4 years, but it came back to the 0.2 threshold. So I had salvage radiation in 2013, and I had another very good nadir, this time 0.014. And I basically thought I was cured, which is a very dangerous thing with this disease. But I stopped having the ultrasensitive tests. They were always less than 0.1 at the regular level, and then I was ready to declare victory. And my 5-year anniversary coming up next month. Unfortunately, my PSA gods, I guess, heard that, and they took vengeance on me, and it came out at 0.2. So, excuse me, I consulted with my doctor, who ran a ultrasensitive, and it's actually 0.0144. Excuse me, I've got some allergies also. Came out at 0.144.
Mm-hmm.
My urologist, actually, he's a combo uro and oncologist, and he'd like to have a conversation with me if it gets to 1 about having ADT.
Mm-hmm.
ADT scares the dickens out of me. I really, really, really never ever want to go on ADT because of the horror stories I have heard. So there are various concerns I have. One concern is, will going on ADT just accelerate this cancer to a castrate resistant stage and just make me go down that road and I die earlier? The other concern I have is, will it make my life so miserable that even if it extends my life, it's really not worth living?
Mm-hmm.
At 72, I figure if I can get 10 years out of this life, I'll be happy.
Mm-hmm.
10 good years. Well, so what I've done is changed my diet drastically. I've looked at all the diet videos. I've gone to, sort of a, Snuffy Myers type Mediterranean diet. I'm taking supplements. I'm taking Pomi tea because I saw a report on that. I'm taking modified citrus pectin because I saw a report on that. And I'm doing whatever I can to fight off the time when I have to have that discussion. So but to now, I have really never communicated with another patient. When I talk about this to my doctor, they don't want to hear about diet. They just want to follow the progression and have this discussion. Although they are willing to talk to me about maybe putting me into some kind of clinical trials, immunology, stuff like that. So that's about it.
Mm-hmm.
That's my story.
Okay. Well, let me ask you a couple of questions, if
Sure.
I may, just to fill in. Where is it that you live? Somewhere on the East Coast.
I live in Virginia, in the Washington DC area, and I'm very fortunate to have access not only to my local urologist oncologist, but I also saw my previous radiation oncologist at Walter Reed, and am making an appointment for Johns Hopkins.
Okay. So, and who is it you hope to see at Hopkins?
Oh gosh, the name. If you give me just 1 second, I'll look it up. It's a name I got. Actually, I get. I'm sorry about that. I get a lot of my information from cancer forums, and the name is Dr. Emmanuel Antonarakis.
Antonarakis. Okay.
Yes.
Okay. So that Antonarakis is a great choice. We can talk about him. We have several people that have seen him.
Oh, good.
So we know of him pretty well. And where is this urologist oncologist?
Well, he is my local guy. His last name is Desai, Desai, and I have been seeing him probably for 12 years. He's the one who originally did the biopsy. Mm-hmm. I have trust in him. It's not that I don't trust him, but it's just that he did not do the radiation, and also he is pretty much a standard of care guy. He is very, very good at standard of care.
Right.
So if he wants to put me on ADT, I have no doubt that he will give me whatever the protocol is for ADT, but he doesn't have the time, or I don't think the inclination to look at alternatives or anything else, and it's very hard for me. He's a very busy guy, so
right.
Well, I don't have much opportunity to talk to him about these other issues.
I've got a couple of guys on this call that I want you to talk to, but the first thing I want to say to you is that we all, pretty much everyone on this call, feels very strongly that when your cancer comes back, you don't want to stay with your urologist.
I'm sorry, what? Could you repeat that?
When your cancer recurs, we don't believe, I don't think there's a man on this call who would choose to stay with his urologist for treatment.
Okay, thank you.
They would be looking initially to a radiation oncologist, and then subsequently to a medical oncologist who specializes in prostate cancer, which we call a genitourinary medical oncologist, or a GU medonc for short. And maybe somebody, Jake, maybe can write genitourinary medical oncologist in the chat window for you, so because it's a bit of a mouthful, but when you see it written out, you'll see what it says. But we feel very strongly that that's the sort of doctor you want to be seeing, and Antonarakis is one of the best in the country as far as that is concerned. So the other thing that I note is really you're still at your nadir, because you said your nadir was 0.014, and when you tested again, you're still at 0.014, correct?
No, I'm sorry. I'm at 0.144.
Ah, 0.144 now.
Yeah, so my doubling time is about 12 months.
Okay. So, and when was that 0.144? This year or last year?
This year, February 1st.
Just done it. Excellent.
Yes.
So I want you, I'd like to throw it out to especially since you haven't talked to any of our guys, and we've got a couple of guys who fall into your category in terms of their experience, and one of them in particular is Peter Kafka. Just a quick shout out to Professor Bill, who I see has joined us. Great to have you back. We haven't talked to you for ages, Bill. And somebody has their volume turned up quite a bit because we're getting an echo.
It's actually Peter, Rick.
Oh, it's Peter. Okay.
I was just getting ready to mute him. But then you're going to call on him to
I am. Okay, Peter, go for it.
Okay. Nelson, I think you've got a little more panic in there than you need right now. If you're at 0.1 and your doubling time is a year, 12 months, you've got several years to go before they'd even consider putting you probably on ADT. I mean, you're in pretty good shape. I'm a little more aggressive than you. I've got a biochemical reoccurrence going on right now as we speak. My doubling time is under 2 months. So I'm going for a scan. I'm just about at the 0.1 level. I do ultrasensitive PSAs every month because my oncologist keeps an eye on it, and I do too, like a hawk. And because I've been for the last 5 months doubling it every little less than 2 months, I'm going for a special scan. But I'm a different case than you. I've got far more aggressive. I've been on ADT. I don't think it's that big a deal. I've been on for 18 months. Almost everybody on this call has probably been on ADT at one time or another, or still on it. And yes, it's a little bit debilitating, but you can find ways around it. I'm on a vacation right now. I've been on a vacation for a year, and it's possible to do that with the situation you're in, to take it for a while and then go off it, and that's what I did. Now I'll probably have to go back on it. I'll know more in a couple of weeks when I meet with my oncologist and get this scan. But I would not panic in your situation. I would write it out. Make sure you've got a genitourinary oncologist as your quarterback there, who you can talk to and monitor this with, and you'll be okay. I think you'll be fine.
Thank you, Peter. Those are reassuring words to hear. I think the source of my panic was my urologist suggesting ADT when it gets to 1, and being at 0.14, I was just projecting out. But yeah, even at 0.14 with a 12-month doubling time, I guess I'm still a couple of years maybe from that point. But what really raised my panic level is I read something that said the following, and maybe you can tell me if this is all wet, that when a man goes on ADT, it takes between 2 and 3 years for it to go castration resistant, I guess they call it.
Mm-hmm.
And then once it gets to that stage, death comes in 2 to 3 years. So when I looked at those numbers, I thought, well, if he puts me on ADT, I better start counting down the 5-year timeline to the grave. Is that completely wrong?
Yes, I think it's completely wrong. I would be more concerned. For me, the game is to not let this disease get metastatic. To me, that's the game. I don't want this to get metastatic. And if ADT can stall that off, more power to it. I'm willing to go back on it. I'm not worried about getting castrate resistant. I'm not worried about the side effects. I've been through it already with ADT. I just don't want to let this thing get metastatic because that changes the game.
Thank you.
Can I interject? Nelson, did you say you read an article that said that if you go on ADT, you'll be castrate resistant within 3 to 5 years? Because nobody can give you. I mean, those.
No, the castration resistance would be between 2 and 3 years, and then that would follow within another 2 to 3 years.
I'd like to see the article because I think it's. I can't say blatantly false, but because I haven't read it and know how you're interpreting it. But there's many gentlemen in this group or people we've heard from that have been on ADT for much longer than 3 years, and it's been effective for much longer than 3 years. And it doesn't necessarily always lead to castrate resistance, at least not in that short a period of time that I've ever heard of. I was on ADT for 2 years and did great. I'm like Peter, I stopped it a little while ago, and currently in the recovery phase. And you did say you had fears about it based on horror stories you've heard. So other than that article you heard about castrate resistance, what are your other fears that we might be able to help you with?
Yes. So I'm as we talk, I'm looking to see if I can find that, that statement. But it's okay. It's good to hear from you guys that you've been through it, and it's good to know that has not been your experience. I did ask my urologist about that, but really I didn't have much time with him, and all he could say, I asked him, look, can you give me 10 to 15 years? That's my time horizon at my age. He said, well, I can give you 5 years. Well, when he says that, and I'm reading this article, I'm thinking, oh crap, 5 years is it. So obviously I'm getting hits and misses I'm getting a noisy transmission link here, and I'm hearing bits and pieces of information that, that are not the full story or even the correct story. As far as the other concern I have, well, this is a TOO. Do you say TOO or us two or what?
Us
Yeah,
too.
us two is a common pronunciation.
Okay, so I went on the us two forum, and I don't know if you gentlemen have been on there lately, but there's a fairly long thread now, and I think the title of it is My Trip to Hell on Lupron. It has something like 50 responses, and there are men there that are pretty much suicidal, and they have talked about the gamut of tremendously bad effects. Keep in mind, now I did ask my urologist also about that. He said, don't look in forums because it's only the guys who really have the bad effects that are going to post on there. And I get that, but that's also why I want to talk to you guys that, you all look very manly. You don't look like you're keeling over. You don't look suicidal to me on the screen that I see. So this is good for me.
So let me jump in, and there are a couple of other people I want you to talk to as well, but let me just jump in. So when I was diagnosed with my prostate cancer back in 2007, and was told that I had to do at least 24 months of ADT, it really concerned me that there was very little support for androgen deprivation therapy. People really didn't understand it, in particular the men who were being placed on it, and the doctors never took the time. And to a certain extent, that's still true. And I think it's absolutely correct what your urologist says, in that the people that are going to shout the loudest are the people that suffer the most. And there are very, very few men who do not suffer on ADT. There are a few who are able to come through their ADT with absolutely minimal side effects. But most people have some issues, but they all consider, I think, that it's probably better than the alternative. Now, one of the things we did is we wrote a pamphlet at UCSF in San Francisco. And I think you should read that pamphlet. It's linked on our website. And if you send me your email address, you can put it in the chat window. You can give it me over the phone. I'll put my email in the window, and you can send it back to me. We'll put you on this list so that you hear about us all the time, every time we have a meeting. And I will send you a link to this pamphlet if you cannot find it on our website. It's under prostate cancer links on our website. I think it's important. Interestingly enough, there's also there's a good article this month in Snuffy's magazine, Prostopedia, on handling anxiety, depression, and depression in prostate cancer. And clearly what you have, thank you for your email address.
I just found the chat window. I had to look for it.
That's okay. Thank you. I've got it. So, if you click on the link that Bill posted a little earlier, you'll find, and you can look later at some of the issues around anxiety, which is what you have. We can hear, and I do think we can put your mind at ease. Is there? Let me see. Is there anyone else on this call? I mean, how about Paul Frieda? I mean, you're sort of along the lines of where Nelson's coming from, right, Paul?
Yes, I am. Yeah. Yeah. Well, for me, it's the uncertainty of when the Lupron will stop working, and then I will go into panic mode and start a new conversation just like this one.
Right.
But the good news is that my oncologist says he thinks I might get another 2 years. So.
And how long have you gotten so far?
I'm hoping right. What?
How long have you gotten so far?
I'm on Lupron now for 2 years and 3 months.
And
I go in next Monday. I go in for my next shot and find out how my blood tests came out.
And how old are you?
70. I'll be 71 in April.
Okay. And by the way, Peter's about that same age, Nelson. So, because age can be a factor here, and the degree of side effects from androgen deprivation therapy can be more severe the younger you are. Paul, would you like to say anything else before I throw it open to others who have had some experience?
Well, yeah, the one thing I've learned is that there's always more information out there, and even if you talk to a doctor that you respect, you really have to keep digging for more information so that you've got a full perspective before you decide to go into panic mode. There's just so much out there and so many different things that people are going to tell you. You just want to keep probing and probing. And as everybody knows, they're coming up with new things every couple months. So, so there's a lot of reasons to be optimistic.
Who else would like to talk to Nelson?
Rick, this is Jim Harrington. I can identify with some of what Nelson said, but Nelson, I think, I also think that we're reading and what you're reading over there is a bit wrong. First of all, I've been on Lupron for 3 or 4 years. I'm a Lupron lifer. I'm also on chemotherapy. So I have an aggressive cancer, but I am actually one of the ones Rick said that really has almost no side effects of this stuff. I don't get hot flashes. I don't get warm flashes. But that's good. But most people do get something along those lines. The point of the ADT is that, it can help you. It can bring your cancer under control. The main thing is, as we said earlier, is to control this stuff. And you're worried about, and you've got fears about Lupron that it's a first line hormonal therapy, and you're going to need it someday, maybe, to, we'll see what Johns Hopkins says, is to really control this disease, and that's what's really important. I wouldn't worry about, you said, it's going to lead to metastatic cancer, and it doesn't do that. I mean, if you don't do anything, then you may have metastatic cancer in a much shorter time. So it's a powerful drug, and it can work, and you can learn to live with these side effects, and you can always join the call, and lots of guys have lots of tips, but if it's something you're going to need someday, I wouldn't shy away from it based on the fact that you're going to have 3 years and out. I mean, I don't know where you came up with that. I just don't think it's right. Anyway, I have Lupron all the time, and I get it every 3 months. And I'm hormone resistant, but nevertheless, I still get it. And, so I wish you the best. I think when you go to Johns Hopkins, that's what you need to do. You need to get a genitourinary type doctor to help you out here. And go beyond the urologist. So you're going the right direction, and you'll get some good advice, I'm sure, from Johns Hopkins.
Well, thank you so much. This has already been very helpful to me, and I feel like I've taken up way too much of your time. So I'll just go ahead and listen to what you guys have to talk about from here on.
Okay, I got one last question, Nelson. You
Sure.
mentioned diet. What are you doing in the way of exercise?
Oh, I do that. I'm fine with that. I work out every day about 30, 45 minutes, and this is wintertime in Virginia. So I'm not playing too much golf, but normally I'm playing golf twice a week, so that's not a problem.
Okay, so that's really important too. We know how important it is, so so that's key. Well, look, we will. Your name will be added to the distribution. I will send you the link to the hormone therapy pamphlet. If you may have found it already. If you browse around our website, there's a lot of good stuff on there. You mentioned you watched some of the nutrition videos. Have you listened to our nutrition presentation by the dietitian from UCSF?
No, I have not, but I will definitely look for that.
Yep, it's linked on. It's in our menu. It's really good. It's recent. It's from August of last year, and Greta spent about an hour and a half talking to us about nutrition. There's a really good deck that goes with it, so I strongly, strongly recommend that. And there are 2 links on that page to nutrition and prostate cancer pamphlets that you'll find useful. Really good. So we recommend that, and keep coming back to us. And you're the second person that I'm saying this to today. Is just be careful what you read on the Inspire blog. I know that Inspire blog very well. I'm fortunate enough and proud to say that I was actually given an award by us too for the work that I did on that blog. And I don't appear on it much anymore because I just don't have the time. And one of the reasons I say that is because when I see stuff that's wrong and posted that's wrong, it bothers me and I feel like I have to jump in and correct it because people are getting bad information. And there's so much that goes up that's wrong that if I was to dedicate my life to correcting the Inspire blog, I wouldn't have time to do all the other stuff I'm doing. And we do have people like Peter, for example, who is on and off, and we have other of our guys who are on and off. But you just have to bear in mind the source of the information. Some of the people on the Inspire blog are really very credible and great sources of information, and others are not. So don't believe everything you read on the Inspire blog. Okay?
I would say in defense of the gentleman who wrote that particular entry that I think he's being very honest. He's suffering all of these effects, and several other men have joined in. I understand, but I'm fully cognizant that this may be an outlier. But
well,
if that's all you have, then you put more weight on it.
Here's where I come from on that. He may be suffering, but what is he doing about it? So what steps has he taken to mitigate? If you read this pamphlet that we put out, we suggest some things that you can do. So if he's having great anxiety, for example, is he taking an antidepressant? Has he talked to his doctor about it? If he's feeling very fatigued, and a lot of guys are, is he doing any exercise?
Good questions, and I don't know.
If he's putting on a lot of weight, has he changed his diet? Is he eating celery and carrots every time he feels hungry, or is he having another donut? So see, this is what I'm saying, that I don't doubt that the fellow that you're talking to, who's writing it, is suffering. And believe me, I and almost everybody else on this call sympathize with him because we've been through it. But what we've learned is that there are ways to handle it. And he's not telling you the ways to handle it. He's complaining, and rightly so. But he's not. I don't know if he's taking the steps to mitigate. Now there are guys. I know guys who have become suicidal, and it's not unusual to become suicidal when you go on ADT because your brain chemistry is being changed by the lack of testosterone. You're not producing the same endorphins that you were before. But there are things you can do about that. And a lot of times these men don't get the support. And another thing that we did at UCSF is we created an ADT clinic so that men that were suffering like that could go to a clinic and they could get medical support. So that's what I'm saying, Nelson. I'm not saying he's not suffering. I'm saying you don't have all the facts.
Yes, thank you. By the way, I did find the article. Okay, I just linked it. That's the one that talks about 2 to 3 years to progression to castration-resistant prostate cancer. And I don't know, it was a different article that talked about survivability of castration-resistant cancer being on the order of 1 to 2 years. So I just did the addition, and I got 5 years. But this is an older article, so I don't know how relevant that is.
There are many men who don't last more than 2 or 3 years before they have to go on to the next drug, but there are also many men that do. So as Bill correctly said, we don't know enough about your prostate cancer to be able to forecast how long you would last, but my suspicion is that you will do quite well because your prostate cancer isn't moving that quickly. For men who have very, very aggressive cancer, they may not get more than 2 or 3 months. And I've known men like that, sadly. They didn't get more than 2 or 3 months out of androgen deprivation therapy. But I've also known men who have got years and years and years. And the problem with our diseases is that it's exceptionally heterogeneous. I mean, it's so different, so that you don't know until you go on it really how long you're going to get. But the good sign for you is your doubling time is slow. Your diagnosis was in 2009. That's 9 years ago. You're 9 years out already, and you haven't had to go on ADT. And those are great. Those are all great signs. So,
well, thank you so much for the positive thoughts and the reassurance.
Pleasure. Okay, I'm going to welcome, I see that, as I said, Professor Bill's on, Eric Bookbinder joined us, Dennis Correa joined us. Let me read down the list of people that I have and make sure that I have everybody. Jake, Len, Nelson, Bill Franklin, David Sibley, Jim Harrington, Larry Fish, Paul Frieda, Peter Kafka, Professor Bill, Eric Bookbinder, and Dennis. Is there anyone else that I've missed?
I'm Sylvester.
Oh, Sylvester! Oh my gosh. Sorry, Sylvester.
That's perfectly okay.
Okay. All right. So let me check in with everybody and see who would like some time today. And just let me know if you'd like some time. You don't get into the issue, but just tell me if you'd like some time. So that way I can figure out how we allocate. So
Rick, we do have one other person on the phone.
Okay.
That just joined us.
Okay.
Would you like to identify yourself? You don't have to if you don't want to.
That might be Dennis. Might be me.
I think it's Dennis.
He did it again. I saw he joined us earlier, and then he does that every damn time.
I thought it was Dennis. I
should have known
it too, but I had already discounted in my mind that it was Dennis. I knew who it was. You can't fool a firefly, as Groucho said. Okay.
One of these days, I'll get a computer with audio on it or something.
There you go. All right. Now, Jake, didn't you see your doctor since we last talked?
Yes, I did.
Okay. You're in for an update, whether you like it or not. Okay. Len. Anything for you?
Had to unmute there. Rick, only if we have time I can talk about the progress that Bill and Larry and I have made with clinicaltrials.gov, but
Okay,
it's not critical.
Super. Yeah. Okay. I'll put you in for a tick, but I'll sort of move it down. Bill Franklin, anything for you, sir?
Yeah, I'll bring something up.
Okay. David Sibley, you would like to give us an update, I'm sure.
Yes, that put me down.
I've got you down. Jim Harrington, anything for you?
No, thanks, Rick. I'll just listen.
Okay. Larry, anything for you?
Yeah, hi. I'm muting. No, I'm good right now, thank you.
Okay. Paul Frieder, anything for you?
No, I'm fine, thanks.
Peter, anything for you?
No, nothing for me.
Okay. Professor Bill, how about an update from you? We haven't heard from you for ages.
Is it absolutely mandated?
we might not
Okay.
get you on again if we don't hear how you're doing.
Okay, I'll give you a
Thank
brief
you,
update.
Bill. Eric, you want to give us an update? Eric, are you with us? Yes. Can you hear us, Eric? Wait, he may have stepped away, so we'll come back to him. Dennis, how about for you?
Nothing, Rick. Doing good here.
Good, good. Sylvester, for you?
No, not tonight. Thanks so much.
Okay, we'll try Eric again, see if he's come back to his phone. Are you there, Eric? All right, we'll stop by Eric a little bit later. Jake, what did your doctor say?
Well, she didn't actually say anything, Rick. I just went to her for my normal Zometa infusion, and I got a blood test as usual. And my PSA did rise a little bit. It went from 0.5, where it's been holding steady for the last 3 or 4 months. It went up to 0.7.
Mm-hmm.
But in fairness, I'm not too concerned about it because I had been sick for about 3 weeks. I had some kind of crap. I don't know what the hell it was, flu or virus or something. Because a lot of my blood readings were kind of out of whack. Some were high, some were low. So I'm not giving it a whole lot of credence, and my PSA went up a little bit.
Mm-hmm.
So I have not actually talked to her about it.
Okay. And when are you due to test again?
Later this month, around the 21st, 22nd.
Okay. So, just keep a close eye on it. Anybody want to say anything to Jake?
I missed that, Jake. What is your latest PSA reading?
0.7, Len. It had been 0.5 for several months. This is on Lupron and Xtandi,
Right.
and it did go up to 0.7. But like I said, I'm not giving it a lot of credence because I had been sick, and a lot of my other blood readings were kind of out of whack too. So I'm hoping that's just an anomaly. We'll see.
Okay.
It goes up
Hoping
again.
too.
Huh?
I'm hoping too.
Well, thank you. If not, then we'll have to see what what the next step is.
Okay.
Sure.
Okay. Well,
Even at 0.7, I'm still not concerned at 0.7. That's not very high.
okay.
Right.
Okay. It's not high enough to convince you that you need to get on that exercise bike, Jake?
I could have a 0 PSA and you'd want me on the exercise bike, Rick.
I figured, I could try. I figured, I'm waiting for that motivation, Jake. I'm waiting. I got to put a little plug in to try and get you moving.
Well, I wasn't going to say anything, but now that you mentioned it, when I was sick and for the last 31 days,
Yeah.
I had gone without a cigarette.
Whoa!
Right. Way to go.
No, I did smoke a couple yesterday and today, but I still, I went 31 days without any cigarettes at all, and I've significantly cut back even now. So.
Good man. Well, seriously.
I know you and Lynn will be proud of me for that.
Oh, we're really proud of you. And now, seriously, if you got on that exercise bike now, it might be the motivation not to pick up another cigarette. Just saying. So moving on.
Moving on.
Jake, it's Larry Fish.
Hi, Larry.
Hey, I had a question. Do you get periodic scans to check if any metastases are clarifying themselves?
No, not really. Probably not as often as some people on here.
Yeah, I noticed that my doctor, if she sees a couple of steady progressions in PSA, even if it's low, she does like to do at least a bone scan and I guess a CAT scan and a bone scan. And then so she has, like, we have a baseline, and she picked up a metastasis 6 months ago that just went, as I went from 0.1 to 0.6 over a period of time. And then we picked it up, we followed it every 3 months. I noticed that when I withdrew androgen, when I withdrew Casodex, it came back down and seems like it resolved itself. But just that idea of every 3 or 6 months having a scan, if your PSA does show a couple of rises, maybe an idea to identify something.
I'm not sure. I'm not sure what else they would do, even if they found new metastases. They already know I have metastatic cancer.
Right.
That's why I'm on the Lupron and the Xtandi. So if a scan showed additional mets, I'm not sure what that would really tell us, other than to enrich the medical profession a little bit more.
Yeah. Did they withdraw Casodex? Have you stopped taking Casodex?
I was on it. I was on Casodex for almost a year. I tried stopping it with the anti-androgen withdrawal for a couple of months, but that did not work. So I was one of the 30% that I was not one of the 30% that it works for. So then she put me on Xtandi.
All right, and one of the other, I mean, not going to belabor this, but one of the other points that was I discussed with my doctor in the case of when you do see some new metastasis, or not when you do, when one does, is that there are these options of going back to think about chasing it down with some radiation, depending on where it is.
Right.
Even considering like liquid biopsy or, to see if there's something that's metastasized that can be actionable. Just the idea that if it does go up 2 or 3 times in a row, even if it stays low, in the 0.1, 0.2, 0.6 range, maybe that idea might be something you might want to discuss. That's what I wanted to suggest.
Right. Well, that's why I said I probably will if it continues to go up. Right now it's just it's never been below 0.5 ever since I've been being treated. Even at the lowest point, it never got below 0.5. So now it's at 0.7. And if it continues to go up, obviously that indicates a problem. And we'll probably need to do a scan and probably need to think about chemo or changing to a Zytiga or something else. But I'm not going to get too worried about one anomalous reading.
No, definitely not. Just that's all I wanted to just mention.
I'll keep that in mind.
Periodic scan idea.
So I just want to say that's really good input for everybody from Larry, and thank you, Larry.
Yeah, thanks.
When was the last time you had a scan, Jake?
Summer of 2015.
Yeah, I mean, you should.
2016.
Yeah, 2016. So, I think that really it should be sort of at least once a year when you've got metastatic cancer, and if nothing else, it gives you an idea of how well your treatments are working, and how many identifiable metastases were there on that scan?
I don't know. They just actually it was not even for prostate cancer. It was for a bladder issue, and so they just noted that there was metastases in my sacrum, my ilium, my iliac wings, my hip, and my spine.
Well,
I don't think they enumerated them.
You know, we all want to see you around for a very long time, and some of us have a greater vested interest than others, as our very capable coordinator of social media, in particular Facebook. So, if not for yourself, for the sake of Answer Cancer, would you do us a favor and ask your doc if you can get a scan, please? So at least we have a reliable baseline.
Well, you've noted before, Rick, that I'm agoraphobic. I'm also scanophobic. I freaked out during a CAT scan. I mean, a MRI. I can do a CAT scan. I can do a bone scan if I have to, but I'm claustrophobic in addition to being agoraphobic. Right. So I avoid it like the plague as much as I can. So I'm not going to commit to that. I'm not going to commit to that for you.
Okay. But what if they could do a CT scan where you just go through the loop? They don't put you in the tube.
I can do a CT. That's not bad. It's just when I had to go in that stupid tube.
So would you talk to her about possibly a CT?
I will. But for some reason, she's hung up on MRIs. She wants to do MRIs all the time.
Okay, well,
and I keep telling her I don't do MRIs, and she still writes me a prescription for an MRI, so I just ignore it.
Okay, but then you've got to tell her that you can't handle an MRI.
Yeah. Okay.
You've got to tell her, you can't handle it. That you're claustrophobic and that you just cannot handle it, and see if she'll do a CT. Okay.
Okay.
We've picked on you enough.
Yeah. I'm not going to do anything for you anymore if you keep picking on me.
Gentlemen, can I just interject a second?
Sure.
As I mentioned when I introduced myself, that I did have a previous commitment, so I think I'm going to have to leave the group now. But I really, really appreciate everything that you told me, and just listening to you, and I'm hoping to be able to join you on a regular basis. Is that tell me again what the schedule is?
Every week we meet at first and third Mondays we meet at 8 o'clock Eastern time, and second and fourth Tuesdays we meet at 6 o'clock Eastern time.
Okay, well, I will look forward to meeting you in a future session, and thank you again.
Thank you, Nelson. Bye.
Bye.
Okay. All right. We're not picking on Jake anymore, because otherwise he won't post what I ask him to post. By the way, one of the things I asked him to post today, which he did very kindly, was to make sure to encourage everybody to subscribe to our YouTube channel. So if anybody on this call has not yet subscribed to our YouTube channel, please do so. We're trying to get to 100 subscribers. I'm not quite sure what the significance is, but Rob Baniscus tells me it's very important that we become branded, and we're at 65. And so anybody we can get to subscribe would be very, very helpful. So if you haven't subscribed to our YouTube channel, please do so. And Jake, thanks for putting it on Facebook. Okay, we'll go to Bill Franklin.
Oh, man, I was busy doing something else. No, I'm listening to all of you guys. All right, I'll just throw mine out there. Maybe Nelson should have stayed on. It deals with ADT. So, just a question I had. So when I started ADT, like I said, I did almost 2 years. I finished in August of last year. So I'm coming up on like 6 months off of ADT. I actually have my blood test for PSA, testosterone, and stuff all tomorrow.
Okay.
But my last testosterone was 17. But I'm pretty sure it's going to be a bit higher just based on how I feel and some other indications. So that question was, so when I started ADT and my testosterone started dropping, which I didn't get really good numbers because I didn't get regular testosterone tests. I just knew it was, plummeting. I had a lot of hot flashes, but then when I kind of got to a point where I was pretty sure it was 0, I didn't have hot flashes very often anymore. I was actually talking, Len and I were talking about this the other day. All the hair on my legs fell out, so I don't know if you guys experienced that, but and Lynn said something similar, except mine started to grow back, and Lynn said his never grew back. And I always had just a slight bit of adult acne, which the whole time I was on ADT, I had 0 acne. So now I'm getting hot flashes again. My hair on my legs is growing back, and I'm getting acne again. So has anybody else experienced, and primarily the hot flash thing? Maybe it's a certain level of testosterone where you get the hot flashes. Like you have enough, you don't. If you don't have enough, you do, and they have 0, you don't. I don't know. Just does anybody else experience anything similar?
Coming off of ADT.
Yeah, coming off of ADT, my hot flashes came back.
No.
And primarily while sleeping. So I'll wake up in the middle of the night. I'll be in the middle of a hot flash. I'll be sweaty. And
oh yeah, see, I'm below.
Yeah,
well,
I've definitely had instances of that happening to me since I came off, and I always get quite nervous and think, oh, it's something related to the cancer, but it has never, thank God, knock on wood, proved to be. Not very often. I would say maybe a dozen times in the last 5 years, but I've definitely had it. I don't give it a lot of thought, and it's not regular. It might happen 2 or 3 times in a week, and then I won't notice it for maybe another 3 years or 2 years.
Right.
And frankly, I've never given it any thought. But yes, I have noticed it. Anybody else?
Yeah, this is Len. Bill, I had a similar path of a few hot flashes, even as my testosterone was rising after going on drug holiday from ADT, maybe up to 4 to 5 months after I was on drug holiday, I'd still get a surprise hot flash every now and then.
Right.
It wasn't until maybe, I guess 7 months when they completely went away. So there's no direct correlation between testosterone level and hot flash. It fluctuates a little bit.
All right.
You'll get that.
Yeah, I wish I would have got more regular tests on the testosterone, but my oncologist said it wasn't necessary because it should be 0, right? And my PSA was 0, so he didn't take testosterone. So. All right. Well, I mean, I'm not too worried about it. I was just curious, and since I had you all here tonight, I thought I would ask.
Well, it's
actually, though, he should be taking testosterone levels because when you're on ADT, because sometimes guys, testosterone is not controlled by the ADT.
Right, and when I started, he took like the first. He did a 3 month and a 3 month, and it was drastically reducing. So he assumed because the PSA was also going down, PSA was at 0. The whole time the PSA was at 0, he didn't take another testosterone test. He didn't start taking them again until I came off of ADT. So I don't know the protocol. So
I can't speak for being off of the ADT. but I do know that once, this is Jake, I do know that once I started, I've been on Lupron since 2012, and then when I started the bicalutamide and then Xtandi, all my hair fell out. My underarm hair, my leg hair, my arm hair, any chest. I never had much chest hair, but even the few little things that I had fell out too. The only thing that didn't fall out was my head hair. Even on my testicles, my hair, my pubic area.
Yeah. I'm not worried about the head hair, as you can tell.
So. I can tell, yeah. So I don't know if that was I attributed that to the Xtandi. That's what it seems like it happened, or it might have been just because I've been on it for 5 years.
Right.
So, and the hot flashes, again, I'm still on it, so I'm a little bit different than you do, but I do get an occasional hot flash at night too. I'll be sleeping. I go to bed, I'm cold, I cover up, and then I wake up and I have to put my legs above the blankets for a few minutes. So.
Oh, I got to completely I got to get out from underneath the blankets and turn a fan on.
Yeah.
Me too with the fan. I have a fan with remote control. In the middle of the night, almost every night I turn it on. Luckily, the fan has like a 1 hour turn off, so I turn it on, and I know that it won't go on for more than an hour.
Right.
$40 at Amazon.
Peter Kafka, I'm sorry, but you're making a lot of noise, so I've muted you. Can you turn down your phone or do something? We're getting a lot of echo from you. We'll check back with you in a minute or so.
Peter, I just unmuted you. Did you want to say anything about hot flashes when your testosterone returns?
No, I would just tell Bill to ask your doc if you could just check testosterone every time you do your PSA. It's such a cheap, easy test. There's no reason why he shouldn't let you test it.
Well, yeah, he's done, and he's done that since when I came off of ADT. So the first that first 3 months he did testosterone and PSA, and he'll do it again tomorrow. That'll be the second one.
Good.
So
yeah,
it was just when the first 6 months, 3 months and 3 months, he tested it while I was on. The ADT started. Of course, the PSA went down to 0. The testosterone was dropping, and he didn't test it again after that. So, because I went back and looked at my log, and I don't have any readings for testosterone, and I would have put them in there if I had lab tests. So,
for some reason, a lot of doctors don't like to do testosterone. You have to kind of ask them and force them to do it.
Correct.
My doctor's in the habit of doing PSA, but I have to ask her every 3 or 4 months to do a testosterone.
Correct. And the thing that bugs me about that is that if you don't check testosterone, you don't know if the LHRH drug is working or not. Because if you start to see a rise in testosterone, it's an indicator that the LHRH drug is not working. And you may even see that before the PSA. So I do think it's important. Let's, if I may, Bill, unless you have any other questions or you want to follow up, we'll move along.
No, I'm good. Thank you.
I just wanted to check in with.
Excuse me, Rick. Didn't Bill say that he was off the LHRH?
Yes.
Yeah.
Okay, so you should be getting your testosterone should be rising.
Right. Correct.
Okay.
I'm just my point was just for people that are still on LHRH.
In general, right?
Right. I just want to check in with Tom Van Zandt, Mr. VZ. Everything good there? Would you like some time tonight?
No, I don't really need any time. I've been battling acute bronchitis ever since the Super Bowl. But cancer-wise, I'm about the same. I'm okay.
Okay. And Jay Krockman, anything for you?
If I get a few minutes, that'd be great.
Okay. And Eric said to me he doesn't have an update. I don't know if he can hear me because he stepped away from the camera. Can you hear me, Eric? Yes. One quick question. Do you have an update on your PSA?
No, I don't.
Okay. All right.
I'm getting
I'm getting tested on Thursday. I'll get it then.
Thanks. Let us know. And no more no more blood pressure crises since last time.
No crises, but I'm still having trouble with it.
Okay.
I also had a bone scan, which has some possibly negative results.
Okay. Well, you know,
I haven't talked to the doctor yet.
Okay. Did you talk to the doctor at all about the ideas of around the steroids causing the blood pressure issues?
Yeah, we're working on it.
Okay, good. Okay, David Sibley.
Yeah, that's me. Can you hear me?
We can hear you, and you are up.
Okay. It's been a while since I've been here, but I'm currently involved with my second round of chemotherapy. And we started chemotherapy back at the end of the year because of the PSA rise. In October, I was 20, PSA was 20, and November it was 30, and then December it went to 40. And that was with docetaxel. We had three treatments with docetaxel. Then I went on to Jevtana, and we went from 50 to 70 to 109, and that was with Jevtana. I'm scheduled for another Jevtana treatment this week. So I would guess that we would call this castrate-resistant. PSA is rising with regardless of what the doctors are doing. I did see Dr. Freilander in San Francisco, and I'm supposed to see him on Friday. He did suggest the trials. I chose to not participate in that particular trials. I will find out if there are any other options out there. So that's kind of what's going on with me.
Couple of questions. How are you doing with your nausea? Have you?
Well, the second round of chemotherapy with the docetaxel, I got sick on each of the 3 docetaxels.
Mm-hmm.
Jevtana, I got sick on that one, and the fifth treatment, the next Jevtana, I did not get sick. I did take Zofran, and I was more diligent about taking that medication, and that seemed to cure that problem of nausea.
Right, because we talked with Christine. I can't remember if it was on this call or if it was on the Caregivers call, and we strongly suggested you ask for Zofran, and we also suggested you go to Jevtana because it had milder side effects.
The side effects have not been unbearable at all.
Okay.
I'm still on Lupron, and I do that once a month, 7.5.
Right. Any reason you like to do it once a month rather than getting a depot shot?
No special reason. I just I'm not sure if every 3 months or every 6 months is better than once a month. I don't know that.
I don't think it's better. It's just more convenient to do it. Say,
my doctor's like 2 minutes away, so.
Okay, but have you not switched your care to Terry Friedlander?
He's part of the team, and yes, everything we do, we run by him.
Okay.
And he's just been a member of my team since the beginning of the year.
Right.
Because I switched from an HMO to a PPO.
Right. So is it your local medical oncologist who's administering the LHRH, or is it a local urologist who's giving that to you?
No, mine is an oncologist, local oncologist.
Okay.
And
And is that local oncologist, that's the guy that's been giving you the docetaxel and the Jeptana, is he cool having Terry Friedlander involved?
yes, they do email back and forth. They're both in the loop. And actually, I have a email into Terry Freelander now.
Right.
We're trying to decide, whether we should stop the Jevtana because it doesn't seem to be working.
Right.
Or would it matter to do another one?
Right.
Treatment.
So the first thing that comes to mind, well, let me just ask you one other question. Do you remember anything about the trial that Terry offered you?
Yeah, it was called ES414. And I did have a consultation with a Dr. Fong over at UCSF Parnassus, is where they do that immunotherapy. And what it involved was hospital stays. It involved trips to San Francisco twice a week, because it was a continuous drip through a port that they would install. And again, as the trials are in UCSF, there would only be around 20 participants in that trial.
And
so I decided not to participate.
Okay.
Because my thought process is leaning towards stopping chemotherapy altogether.
But this wasn't chemotherapy he was suggesting, right? It was an immunotherapy drug.
It was immunotherapy, and the way he had explained it to me, that the drug was designed to pull the white blood cell and the cancer cell together, so the white blood cells could actively work on the cancer cells.
Do you recall what
they did not have a name for the drug? It was just ES414.
Okay. Well, Dr. Fong is in my opinion, the best doctor that's in the whole system.
Oh, really? Okay.
He is an incredible doctor. Unbelievable. I know him very, very well. He's on our advisory board. He's also the director, the co-director of the new immuno-oncology clinic, and they're building a new building for him, a 200,000 square foot building, and which for me and for Answer Cancer and the Reluctant Brotherhood is very exciting, because they're going to be exhibiting our buddy Jerry's paintings in there. They accepted 18 paintings from Jerry to exhibit in there. Larry was Jerry's doctor. So I think that in terms of what they're offering you in state of the art, probably doesn't get much better. And I have great confidence in Larry, but that doesn't get away from the fact that this requires a couple of trips into San Francisco on a regular basis, and that for you, lifestyle-wise, it might not be the best option. But having said that, I'm sure, and I'm not familiar with this ES414. Eric, are you familiar with ES414? Is it anything that Agarwal has discussed with you?
No, I'm not familiar with it in particular, but if you just type in ES414 and Google, it brings it right up.
Yeah, I'm sure. So I'll do that afterwards. The one thing that probably is required, and I think we've discussed this before, has your tumor ever been sequenced, David?
No, we did talk about, see, because my metastases are in the bone and some of the lymph nodes. And sequence, you mean like biopsy of that?
Yeah. So I mean, you have metastasis in your shoulder, correct?
Yeah, there's one in the shoulder, and then it's in the lower back and the pelvic here.
So the shoulder should be pretty accessible, and it's not it's a strange process. I wouldn't say it's a painful process, but they take a bone biopsy and they send it away. Either they send it in-house, which takes about 6 weeks at UCSF, or they can send it down to Foundation Medicine, which is pretty much covered by your Medicare. And you know, I would say that that's something. When are you seeing Terry?
Friday.
I would have that right on the top of my list.
Okay.
Because that's going to indicate if you have any mutations and if there are any drugs that are already out there that are not chemotherapy that might be appropriate.
Well, he did suggest that there's a drug out there, and I think it was a breast cancer drug that they've been playing with in the prostate cancer area.
Yeah, I think what you may be thinking of, but we would know, is he might be thinking of olaparib or Lynparza for a BRCA mutation. Did he talk to you? Are you about a BRCA mutation?
No, that's an unfamiliar term.
Okay. So, or it could be a different breast cancer drug, but that is a drug that's used, and Professor Bill is an expert on that drug, by the way. But really, what the first step is to see where your mutations are, because otherwise, it's like sort of shooting fish in a barrel. Well, no, that's not what I wanted to say. It's the opposite of shooting fish in a barrel. You know, it's like looking for a needle in a haystack. We don't know what drug you're going to respond to. So the first thing to do is to do the biopsy. And if you send it off to Foundation Medicine, I mean, if Terry says, "Oh, that's a good idea," and you say to him, "Look, I'd rather it goes to Foundation Medicine than it goes to UCSF, because you'll get the results in about 2 weeks versus about 6 weeks."
Okay.
And time is of the essence if it's not working. The other drug that he may discuss with you is carboplatin.
Yeah, that has been brought up.
And some men do very well on carboplatin and don't find too many side effects. Our treasurer, Secretary Treasurer, Rob Beniscus, just had his fourth. He's going through weekly infusions, and he just had his third weekly infusion of carboplatin yesterday, and he's had some issues, but nothing too serious. And there are other men. I don't think there's anyone on the call. Jim, you?
No, I am.
Oh, that's
Eric. I'm on carboplatin, and as well as Jeftana.
How? But you're on carboplatin with Jeftana, correct?
That's correct. I started out with carboplatin for 3 infusions, and then we went to both. And I've had, well, except for this low blood pressure thing, that's the only side effect that I've had, really.
Right.
Some nausea.
And how are you able to compare the carboplatin to a taxane-based chemo?
I'm sorry, to what?
Are you able to compare the carboplatin to a taxane-based chemo?
Oh, like docetaxel?
Or Jeftana?
But the docetaxel, I had really bad reactions to it. Just, I lost 35 pounds and was sick the whole time. I do have some nausea with the Jeftana, and then I have the low blood pressure problem. But mostly it doesn't affect my day-to-day life.
Okay. Well,
any result on your PSA, Eric? Did that help with that at all?
Yeah, the PSA had hit a high of 50 and it's down to 15 now. I haven't had one for a few weeks. So I'll find out if it's still going down, but it was going down very dramatically.
So, you know, I'll let me throw it open for some other suggestions from other guys, but I would definitely have a sequencing on the top of my list. I would be wanting to talk to him about carboplatin, and if he's got any ideas of drugs, come back to us and talk to us about what those drugs are, because there's a good chance that we might know them if they're not drugs that are just in trial, like the ES414. Although I will educate myself on the ES414. Let me throw it open. Who else would like to speak to David on what to talk to Dr. Friedlander about on Friday?
Oh, it's Jim Harrington, Rick. I'd like to make a comment or two. I have a very sort of a similar situation, except I'm on docetaxel. I have not gone to carboplatin yet, but I'm sure it's coming. But I've been on this for about 5 months. I've had 15 or so docetaxel, and actually I tolerate it pretty well. I guess I'm just kind of fortunate. I don't have any nausea. Mm-hmm. And I've been able to learn how to handle it. I go through a nadir. I just get tired and a little bit of stomach pain. But other than that, the docetaxel, I get it every 2 weeks. I would say, with respect to switch back to getting a sequence and getting a biopsy, I'm setting up for a biopsy of my lymph nodes. I have a very similar case. My lymph nodes are involved in my liver and in my lung, and also I have tons of bone mets up and down my spine. The only thing I would mention is what my doctors mentioned is don't try to biopsy a bone met because you don't get enough tissue. Now, that's the opinion of my med-onc. I'd rather go on in and get the lymph node. So it's a little bit involved, and I guess there's a little bit of pain, at least the next day, but I'm scheduling this where they can get at the lymph node. If they can't get at the lymph node because they got to poke the thing.
Jim, let me interrupt you. I think that might be true in your case because the mets are on the spine, and trying to get a bone biopsy from a spine or bone met can be quite tricky.
Yeah, that's right, Rick. Right. I agree.
And you don't have a decent sized metastasis in a spot like in your in your pelvis, your hips, your shoulder.
That's right. That's right. You're right. It's just that's correct.
David has that shoulder spot. Which
I see. Okay, that's a good point.
Place to take a biopsy from, and they can probably get enough tissue. So I don't think that I'm not saying it isn't true for you. I don't think it would be true for David, though.
That's fine. I agree.
Dr. Freilander talked about a lymph node in the armpit that he could get to.
Okay.
And so that might be easier.
Okay, even better.
Yeah.
Even better. And there's research that says that it's likely that wherever those metastases are in your body, as far as prostate cancer is concerned, they're all going to show you exactly the same genomic sequencing. In other words, if they took something from your armpit and they took something from your shoulder, they would be identical.
Okay.
Anyone else like to say anything to David?
I'll just reiterate. This is Bill Burhans, David. That I agree with Rick and others that it would be really important in your case to try to get your tumor DNA sequenced. That's going to really help down the road identifying drugs that would be effective for you.
Okay, and I've got that on my notes, and I know Dr. Freilander had talked about that. So I'll talk to him again Friday on that.
Okay, good. And tell Christine we haven't heard her voice in a while, and we miss her. And you can also, you are very fortunate to have such an attentive daughter, I will tell you, because you know, a lot of this treatment that you're doing now is because of the intervention that she's done and speaking to us. And oh, she's on the call.
Correct.
She just sent me a message. Okay. So, you know, I'm so pleased that to see you with Terry, because I think he's a fabulous doctor. And he's concerned about you. I mean, I will tell you, I don't know if Christine passed it on to you, but when I saw him in November at the meeting, and the research meeting at UCSF, he said, "What happened to David Sibley? I haven't heard from him." And we said, "Well, we're trying to get him back to you." And so we've done it. And, you know, I think he has a real interest in helping you.
All right.
And so would you like to introduce us to whoever it is sitting on your left shoulder?
This is my favorite son, Paul.
Hello. Hi, Paul.
This is Christine's older brother.
Ah.
And he's out here for a week from North Carolina.
Okay.
Because I'm in California, Castro Valley.
Right.
And so he's taking charge of my care for a week.
Okay. You're giving your sister a break, eh? Well, you know, you two, by the way, are very welcome on the Caregivers call anytime you want to come on. Christine will tell you how to get onto that call. We just please tell us how you do on Friday. Who's going with you to see Terry?
Christine will go, and Paul will go together.
Great. Okay. Well, we will. We look forward to you. You've got your to-do list. We've given you your homework.
Right, you did. Thank you very much.
Okay, and hopefully you will come back and tell us what you're going to do next.
Oh yes, I will do that.
Thank you.
I wanted to ask Dave one quick question.
Yes.
As your PSA was going up dramatically, didn't you feel worse? Did you feel sick when your PSA was going up so dramatically?
Not at all. My big problem is fatigue. But when I get out and walk, I do walk a mile plus a day, and I always feel better when I push through that.
Mm-hmm. Yeah, I mean, there's no question the exercise is going to make you feel better in my mind, and I think in the mind of most of the people that are on this call will tell you that if they can get themselves to exercise, that they feel a heck of a lot better for it. It would be great if you could add some resistance exercise too, at home maybe.
Well, I had in the past, I was doing a yoga program every morning, but that's kind of slipped away. I just have lost desire to do that, or it just hasn't happened for whatever reason.
Well, you know, the MAN plan, I think we've talked about the MAN plan before, but the MAN plan might be a good idea for you, where they give you the bands and they help you work through. Send me a note if you want more information on the MAN plan. Just getting some light weights and having them at home. But the walking is terrific. I don't want to discourage you in any way, shape, or form. It's key. The other thing is that you do need to add a little bit of resistance exercise to that. We know that.
Okay. Yes.
And Paul, are you getting yourself tested for PSA?
Oh yeah, I just had one that was 0.05 last.
Great. Okay. Just want to make sure. Okay. Excellent. Well, we'll move on, and we look forward to a good report.
Okay. Thank you.
Professor Bill, welcome back to the call.
I was hoping we'd run out of time.
What's that?
So I said I was hoping to run out of time, then I wouldn't have to give you the mandatory update. I'm joking. I'm happy to give it. I'm back in Vermont, where it's very cold, and I'm snowshoeing every day, which is what I consider to be one of the best medicines.
Yeah.
Although I've been looking at that palm tree. Now it's dark in the window behind Len, but I could see a palm tree there earlier in the call, and one looked pretty attractive too. So I don't remember where we were at the last time I talked to you guys, but I think I had. I think I was going through. I had UTI issues.
Yes.
And
Yep.
and I think since then I had another one. I was back in the hospital for a UTI. You know, they're. I have them more frequently than I would like because I catheterize.
Right.
And so they put me on the. I hung out in the hospital for a couple of days on IV antibiotics, and that took care of it again. I had been on a prophylactic dose of amoxicillin for the past year and didn't have a problem with UTIs at all. And then the infectious disease guys at Roswell Park, where I'm being treated, recommended to my urologist, who's not treating me. She treats me for all the side effects, not for the cancer. and he recommended that I go off it. And I had these 2 rounds of UTIs that put me in the hospital, and so that, you know, I put an end to that. I'm back on the amoxicillin prophylactically, and so far I haven't had another UTI. My PSA is going up, so I've been on olaparib for almost 3 years. I'm I think probably most of you know that my cancer is driven by a mutation in the BRCA2 gene, and olaparib is a drug that interacts with it. I think that my course with olaparib is running out. My PSA began to go up last fall. It took a big jump back sometime in December, I think, from about, I don't even remember, but it jumped about 1.5 points up to about 2. And then about a month ago, it jumped again up to 4.5. Sorry, there was an intervening reading there of about 3.2. So it's going up pretty rapidly, and some of it could be attributed to the UTIs. There's no doubt that an infection can cause PSA to go up even that much, and but I think there's little doubt that there's something going on beyond just the effects of the UTIs. So we're making, we meaning my oncologist and I, are making plans to do something else. And his recommendation is that I stay on olaparib and add Keytruda to the mix. Keytruda is a checkpoint PD-1 inhibiting drug, which doesn't work very well for prostate cancer patients in general, but it works better for patients that have defects in DNA repair, which is what my BRCA2 mutation causes. And so the plan is to begin Keytruda when I get back to Buffalo in early March. I'm not convinced that that's the right way to go. I still think that finding a next generation PARP inhibitor, which is olaparib was the first of the PARP inhibitors. I'm not convinced that one of the newer PARP inhibitors that are a couple of orders of magnitude more effective in preclinical studies might be better that I need to have my tumor cell DNA sequenced to see whether or not I've had a reversion mutation, because if I have had one, then PARP inhibitors just won't work. You tried to draw blood for a liquid biopsy by a company, a new startup company at Roswell Park, but they weren't able to get any blood out of me. I think mostly because the guys doing it aren't used to drawing blood. So when I get back to Buffalo, that's another thing that we plan to do, is to make another attempt to get enough blood for a liquid biopsy. And if it fails again, then I'm going to go to Foundation Medicine and use their Foundation Act test. I also have some biopsy material from 2016, I think, that's available that we might use, but you know, I think it's important to try to get some material that's more current than 2016. So that's about it. I have to say I haven't really been doing much about this. You know, I've been really busy, but I realize now that things are getting a little bit more critical. And so I've given the word to Roswell Park that I'm going to shut down my lab in another couple of months, and so I can invest more time in figuring out exactly how I should be treated. So that's about it.
Well, that's a lot. That's a lot, Bill. A few things immediately jump to mind, and I'm sure a bunch of other people have got questions for you. But the first thing I just want to ask you is that was there ever any traction with Pfizer or with Tom Harding at Clovis?
No, I never heard back from him. I sent multiple emails.
And you never heard back from either of them, huh?
No, and Larry, where is Larry Fong? Is he at Pfizer?
No, Larry Fong, Tom Harding is at Pfizer.
Okay, yeah, no, so I haven't heard from these guys. I mean, I didn't. I'll try again, Rick.
It's okay, and I'm making a note, and I will chase them up too, and see what I can do. But I do think that maybe before I do that, it would be good to get you sequenced. Is there any reason why you cannot do a solid tumor sequence?
No. I mean, I do have material. Well, I think that I have some material from a TERP that my urologist performed in the fall of 2016.
Okay, but what about recently though? Can we not get a solid tumor sample right now?
No, there's nothing. You know, there's nothing large enough. I should have added that I've had you know, a bone scan again. I have them about once every 3 months.
Right.
And the last one was right before I came up here to Vermont at the beginning of February.
Right.
And so the bone scan shows, you know, it's a mixed result. There are, you know, some lesions are disappearing and there are new ones appearing, which has been pretty much the case, you know, for the last year or so. But none of them are large enough at this point to warrant biopsy.
Mm-hmm. Okay.
So yeah, so except for, you know, previously collected material, there's not, you know, I think I'm stuck with a liquid biopsy at this point.
Well, I mean, I agree with you. I don't think there's a lot of point, especially given that you suspect that not suspect, but there's a possibility that the mutation might have reversed itself. I think you've got to go
Right.
with a new sequence.
But that's what I need to find out. That's the most important piece of information that I need
exactly.
from this.
Exactly. And so what I would say is, as soon as you have a new sequence, let me know, and then we'll reach out to Pfizer and to Tom Harding again at Clovis.
Yeah, okay. I mean, but you know, my thinking is, let's just do it with the new generation PARP inhibitors. You know, I'm not sure how important the sequencing is. I mean, it's the possibility that the mutation is reverted is actually not that great, and I don't quite, you know, it seems like we should just go ahead and try it independently of the sequence information, and if it works, it works. If it doesn't, then you know, we'll have to think about something else.
Right.
I suppose
we
the cost is.
Yeah, I mean, we can talk about that. I think it's more likely to strike a chord with these manufacturers if they know that you are a prospective candidate versus
right, that it hasn't reverted, right?
Exactly.
No, yeah.
I mean, that's the reason why I'm suggesting you do it. Let me ask you one other question. What chemotherapy have you ever done?
I've never had chemotherapy, cytotoxic chemotherapy.
Right.
I'm on olaparib, and I'm still on Xtandi, and so, you know, I should say the plan is to keep both of them going.
Okay. I mean,
and then
is that a discussion that would it be appropriate in your case, a chemotherapy regime or not?
It probably is. I just, to tell you the truth, I'm afraid of going that route, but that's, you know, it's crazy, it's irrational. You know, I think that especially, you know, listening to some of the rest of you who have been through it or are going through it now, you know, I should consider it more carefully. But it's also the case, you know, I haven't brought it up with my oncologist, but he also hasn't brought it up either. I haven't not done it because I've told him that I'm not willing to do it. I mean, so what do you think? That's something that you think is appropriate at this stage?
There's a couple of things. First of all, you know, when you say you're an oncologist, I think, are you talking about Jim Muller?
No, Jim is following my case, but he's a surgeon.
Okay.
And you know, he's following my case as a friend.
Okay.
And, my oncologist is Kamal Chadha. I don't know if you've run across that name. So he's a medical oncologist.
And he specializes in, he's a GU med onc, or
Oh yeah. Yes. Yeah.
Well, I have a couple of thoughts, Bill. I mean, the first thing is that, and this is something I suggested to Rob recently, and he picked up on, is maybe it's worth getting a second opinion from to introduce into the mix, and
yeah,
and to go to one of these really, you know, one of the names we recognize and consider to be an expert. I mean, maybe Chris, what's his name at Dana-Farber? I want to say Williams. It's not Williams. Or Alicia Morgans, or you know, one of the people at MSKCC. Although I suspect not, because I know you haven't had a great relationship there. But you know, we can reach out to a bunch of really good people.
Yeah, no, I think I know who you're speaking of, that Dana Farber, and it's someone that I have spoken with in the past, and he's been not just willing to help, but he was anxious to get involved with someone, you know, with my background and my disease parameters. So I will track down who that is.
Chris Sweeney.
Just to make sure it's the same person, if you could email me the name of the person you're thinking of, that would be helpful.
It's the name I'm thinking of is Chris Sweeney.
Chris Sweeney. Okay.
Yeah, and
yeah,
I'm gonna put his his resume or his reference in the chat window for you momentarily. But
okay.
You know, Sweeney is great. He's one of the guys that appears on those webinars with along with Morgans and Chuck Ryan.
Yeah.
And I think he's really good.
Okay, good. I'm glad to hear that. I really
value
opinion about these guys.
Except that he's an Aussie. Just telling you up front.
He's a what?
He's an
Aussie?
Yeah.
Oh. I can't go to anyone that has any kind of a British accent. I don't.
Well, I wouldn't worry about that. I just worry if he was standing on his head, to be honest. Okay, I've just put his reference in the chat window, and call me and we can talk more about that. Let me throw it open because I'm sure there are people really anxious to talk to you. Go ahead. Go.
Yeah, Rick, it's Len.
Yeah.
I just want to bring to Bill's attention something I just put in the chat box. Being that he was considering Keytruda or pembrolizumab. This comes from State of the Science report sponsored by the Prostate Cancer Foundation, an attempt to explain why they haven't been very effective for prostate cancer, the checkpoint inhibitors. And so I'll take a moment to read that.
Yeah, I see it. Thanks, Len.
Yeah.
I'm aware of the fact that checkpoint inhibitor immunotherapy is not very effective for some reason for prostate cancer patients. Not nearly as effective as other types of cancer. But the few cases that I'm aware of where it is effective are ones where the patient had DNA repair mutations like mine that can generate lots of new antigens. And so it makes sense to me that it would be more effective for someone like me. But still, this is largely the reason why I'm not too keen on going forward with this approach, because I know that it's not, it hasn't worked well for most prostate cancer patients.
Right. But what they seem to be expressing there is the fact that possibly they would work well with a vaccine, something like Prostvax, which failed, but because it was used alone. But anyway, the other thing is, I would argue against chemotherapy because you have, of course, an actionable target already. I would think chemo would be more for those folks who don't have any actionable targets. So going with a more potent PARP inhibitor would seem like a better route than a sledgehammer chemo approach.
Yeah, and that's part of my, I agree. That's part of my reasoning. It is the case, though, that drugs like carboplatin, because it's a DNA damaging drug, it can be synthetic with DNA repair mutations. And so you could almost consider it to be a, sort of a broader version of a targeted therapy. And
Okay.
but still, I don't. I agree. I think it would be better, that there are other options that I need to explore before I go to chemotherapy. Thanks for giving me the excuse for not moving forward with that, if that's where things head over the next month or so.
Well, it was carboplatin. I mean, I had carboplatin in mind, but I didn't want to get into detail. I mean, I tend to agree that probably a taxane base is not the right thing, but
right.
I mean, everything's open for the discussion, and that's also why I think it would be a good idea to get some new thoughts in, from a Sweeney or a Morgans or a Ryan or somebody like that, or Paul Korn at MD Anderson, or Dan George at Duke. These are all people we can get to.
Yeah, you're absolutely right. I just need to do it. I mean, I'm not making excuses. But I just, it's been too easy to focus on doing the things I really like to do than doing this stuff. And
well, God bless you. I mean, you're out there You're out there snowshoeing with Buzz and Chris. Please give them my love and tell them I would like to be snowshoeing there too if I could stay warm enough. But
yeah, I will. They speak about you frequently. We had
politely, or I know they
think great.
They only speak about me when they need wood in the house. That's the only time.
No, they want you to. They hope that you come back.
Okay. Okay. All right. Well, we have to let you go, Bill, because you've got to bring some wood in, right?
Yeah, right. Yeah. My older brother was always trying to get me to stack wood. I'll tell him that you said that.
Yeah.
Hey, Bill, anytime you want to trade your snowshoes for sandals, come on down here.
Okay, thanks, Len. I appreciate it.
Anybody else like to talk to Bill before we go on to Jay Kruckman? Okay, Bill. Well, look, let's talk soon. Let's, again, like with David, I think the priority is to get something recent sequenced and see where you are.
Yeah.
Okay.
Yeah, I'll have more specific information for you.
And
I'm not going to let time elapse as between my participation in these calls as has been until now. I'll be a better participant, and I'll update you in another week.
And how long are you in Vermont for?
Until the beginning of March.
Oh, great. Okay, so I'll talk to you for sure in the next couple of days and say hello to Buzz and Chris at the same time. So. Okay.
Terrific.
Okay. Jay Kruckman, you're up.
Thank you. I met with a new oncologist today. Had blood work done yesterday, and I wasn't real thrilled with the last oncologist in regards to the treatment plan that they had. So found another one here locally, and my PSA continues to rise at a rate that appears to double about every 8 weeks. I went from a 1.2 to a 2.1 in a little bit under 6 weeks. So yeah, that's exactly what I estimated it would be, and unfortunately that's what it was. Mm-hmm. So he came in and he seemed very knowledgeable, explained from the get-go without, said, this is where I'm starting from, and you may know all of this, but I'm going to go from the beginning and explain the whole process of how to treat different prostate cancers and things of that nature. So I think it's a good fit right now. I liked his thought process. He offered up ADT treatment again, ADT treatment with a Extiva or Zytiga, Provenge, chemo. Also very concerned about costs and what's in my plan and what's not in my plan. I have a CT scan scheduled for tomorrow, and then I have a pelvic MRI with an endorectal coil on Monday.
Mm-hmm.
And that is totally new to me. But he said we're trying to find out where it's at a 2.1, somewhere we probably should start detecting where the cancer may be. So he also wanted to present every Thursday. They meet with the tumor board. He wanted to present my case to the tumor board there to get the opinions of everybody else that participates. So that's just updating, and now I'm just trying to figure out if, who knows what and where I need to go. He came in very aware of my case and explained where I was at each stage, which impressed me because I have not had that in the past.
Which hospital is he affiliated with, or which group is he affiliated with, Ray? Jay?
It's with the West Cancer Clinic in Memphis.
Okay.
He is the head of the prostate oncology. So.
Okay. And what's the guy's name?
It is Kurt Tauer, Tauer.
Tauer. Okay. And did you talk to him about an Axumin scan?
I did not get there. He was very much understanding where we were at, or I felt where we're at, and wanted to do these scans first. I had not gotten to that point yet.
Okay. So an Axumin scan might be really appropriate for you right now. You're probably a really good candidate for something like that, and it's most likely to show something. And so I would, if he's going to put you through all these scans, I think that's what if it were me, that's what I would be pushing for right now. Len, what was it you just read? I know you just read an article, I saw it too, but what was it that you read about the Axumin scan? We can't hear you, Len.
Can't hear you. Sorry, I forgot to unmute myself. It was an article from. I'm getting feedback. Hold on. I don't know if that's me.
No, it's from caller number 8. I've got to check in. That's probably Peter, but I've muted him. Please go ahead.
Yeah. So there's an article from Medscape talking about how Axumin is now changing clinical practice for medical oncologists because it's providing more accurate scans following biochemical recurrence of prostate cancer. It's already approved, so that's perhaps the biggest advantage, mostly covered by insurance and I believe by Medicare. Of course, the more experimental, at least in the U.S., gallium-68 PSMA scan is even more accurate, more sensitive, but it's not approved yet, so you'd have to get into a trial if you wanted to use that scan. Was that the article you were talking about, Rick?
Yes, it was.
Yeah.
And I think I missed last week, but the week before, I think you gave me that information, and the closest place for that type of scan is either in Birmingham, Alabama, or Chattanooga. So I figured I'd give them the benefit of the doubt here. They schedule these scans. I met them today. I got CT tomorrow and a MRI on Monday. And depending on the results of that, I would bring that up, but there's nothing close by right now for the Axiom scan.
Now, the other thing that might be important to you, as far as you know right now, you don't see any sort of metastasis. Is that correct, Jay?
Correct. I had a bone scan the first part of December, and there was nothing.
The FDA just approved well, there are a couple of things. Xtandi and apalutamide just produced results that are very positive for somebody like yourself, where you're becoming castrate resistant, and you start using Xtandi or apalutamide right away. Now, apalutamide hasn't been approved yet, but Xtandi has, and they're showing quite an extraordinary difference. I think something like 26 months difference in disease progression between men who start Xtandi now and versus men who stay on just ADT alone. So, you know, the idea of starting Xtandi early is exactly what was discussed, and Tower should probably be familiar with that. It was announced, those results were announced by Maha Hussein last week at the GU conference.
And actually, he was familiar with that, which, you know, led me to believe more in him, I believe. We talked about adding different treatments and everything else, and he was, my impression, and I think he shares the same thing, you know, if you're going to get 21 months or 24 months, I'm sorry, for me, that's not a big difference. But if you're going to get 24 extra months or 26 extra months, that does make a significant difference to me.
Right, so. And that is disease progression. That's not overall survival.
Right.
Okay. Yes. The other thing, but it isn't really so appropriate for you because you appear to be castrate resistant now, is that abiraterone was approved for use in men who are castrate naive, which is pretty important.
Well, I'm as far as I think, I'm still castrate naive because I took myself off the Lupron.
Oh, that's right. I forgot about that.
Effects.
Correct.
Yeah, the side effects.
Right.
So,
correct.
But he was very understanding of the side effects and said, you know, the treatment you need is something you don't tolerate well. So that's what we're trying to deal with.
You know, so that's also important because if you wanted to go back on, then abiraterone is now FDA approved for you.
Okay.
Which could make a huge difference in its availability to you.
Correct. So.
Because most likely you would be castrate sensitive if you went back on. Look, I don't want to hang everybody up, and Len, I'm really sorry that we didn't have time for the clinical trials discussion, and Larry and Bill. But I'll make a commitment to talk about it next time. We'll talk about it early next time. There was a really strange, I sent it to you guys and to Bill. There was a kind of strange poster at ASCO that I read about clinical trials, which seemed to have some inconsistencies. I sent it to you, right, Len?
I saw it. I'm not sure. Yeah, I guess if Bill saw it, I must have seen it.
Yeah, Bill saw it for sure. I mean, it basically said that men, the way I read it, it was saying, one, that men who have prostate cancer are actually more likely to participate in in clinical trials than with other cancers.
Yes.
But then it also went on to say that 75% of all men are informed about trials, but don't do anything about it. But don't. So men are told about trials with prostate cancer, but they don't pursue it, which was sort of flies in the face of the other one, which says 33% of men with advanced cancer have at some point or the other been exposed to trials, which seemed like quite a high number. But am I remembering it right, Professor?
Yeah, no, that's correct. Yeah.
Okay.
Yeah, it was kind of a strange result, but in any case, we don't have much to tell you actually at this point, right, Len and Larry?
Yeah, not a lot.
But
better if we wait.
Yeah, we'll have more to tell you next week. Basically, we're making progress towards setting up something that will help everybody on the call identify appropriate clinical trials. So we'll let you know more about it next time.
Excellent. All right, guys. Well, thanks for bearing with us. The next call will be next Monday, the 19th. I wish all of you a happy Valentine's Day. Don't forget the roses and the flowers and chocolates for those important caregivers in your life, please. And we'll talk to you soon.
All right. Thanks. Good night, everybody.
Good night, everybody. Thank you, Rick.
Good night.
Night.
Good night.
Good night.